Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Alex Lutz, the VP of Marketing and Public Relations at RUMC. Our special guest of the day, Kristine Delgado, who is the Administrative Director of our Rehabilitation Program at RUMC, as well as Dan Ryan, the Advertising Director here at the Staten Island Advance. Welcome, everyone.
Thank you.
Good seeing you.
Through RUMC Connections, you will meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We will provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your health-related questions. As a parent, you want to see your child grow, learn, become independent, and thrive. When it comes to pediatric rehab, ideally, parents want a program that treats their child's current physical, emotional, academic, and social challenges. RUMC provides comprehensive pediatric rehabilitation services from birth through 3 years old. There is also a NICU graduate program, a sensory gym, and flexible hours to accommodate working parents and school-age children. Joining me today, like I mentioned, is Kristine Delgado, our Administrative Director of Rehabilitation. Kristine joined the RUMC family back in 2013 as a speech-language pathologist before becoming promoted to her current role in 2019. She now oversees inpatient and outpatient physical, occupational, and speech therapy, as well as cardiopulmonary rehabilitation. Kristine has 17 years of experience in the field of rehabilitation, specializing in swallowing disorders, head and neck oncology, and medically complex tracheotomized, ventilator-dependent patients. Prior to coming to RUMC, Kristine worked as a speech pathologist in the brain trauma unit at JFK Medical Center in Edison, New Jersey, and St. Peter's Medical Center in New Brunswick, New Jersey. She also worked as the senior speech pathologist at Egger Healthcare and Rehabilitation Center in Staten Island. Kristine graduated with both a Master and Bachelor of Arts in Speech Pathology from St. John's University in Queens, New York. So welcome, Kristine. Please tell us about the pediatric rehab program and the specific services that are offered at RUMC.
At RUMC, we have a rehab program that caters to both adults and pediatric. Specifically, the pediatric program, we offer speech, occupational, and physical therapy for children from birth all the way through adolescence. I think our youngest patient was probably 21 days old. So we have the whole range of services, and my therapists are specially trained for neonatal as well as feeding, complex feeding disorders. It's a great program we worked really hard to establish.
This is all on the campus?
Yes. Yeah. It's we're in the resident building, which is like it's the back of the parking lot of the hospital.
When they're that young, what are some of the conditions that you're treating?
It's really a range. For pediatric, it can be something that a child that has autism, developmental delay. Some children have like high muscle tone or low muscle tone because they're born premature, which is where the NICU babies come in. You know, we're getting them like really young from the NICU because they have maybe some prematurity-related issues. It could be sensory issues, just some children with articulation. So it's really a range.
So are the NICU babies brought over to the rehab, or do the therapists go to the NICU to work with them?
So actually both. So in the patient, we have a whole inpatient team.
Okay.
That sees the babies when they're in the NICU in the hospital. And then Dr. Parab and he's our NICU intensivist. Him and I developed what we call a NICU graduate program. So the babies are referred to us. So if they're getting services in the hospital, basically they're referred to us upon discharge. So we usually see them within 2 to 3 weeks of discharge. The parents bring them, and we do an assessment, and we start services with them. I would say pretty much 80% of the time we're starting services, and some of the time we're just telling the parents, listen, come back in 3 months or 4 months, and we're giving them things to look for. So that's been our NICU program. It's very unique. I don't know of many other places that have that. And the parents, they love it because they feel after going through the NICU experience, they are very anxious and they like the fact that they can, bring their baby home, but they're having another set of eyes, and the baby's able to work on some of the things services they were getting in the hospital.
How long has the program been in existence, and how many graduates have you worked with?
We started back in 2021, I think, or maybe 2022, probably early 2022. And I'd say we've had, at least 100 babies already. Yeah.
And that just aids to like why RUMC's special with being known as the baby hospital.
Right.
Yeah.
Being
very
baby
unique.
friendly is,
Yeah, it's a very unique program and something we're really proud of, and we couldn't have done it without the NICU collaboration because, they're where it starts. They have to refer the baby over, so they're really good about that, and then we get the baby right in the schedule, and it's been great.
And is it more of the NICU graduates? Is it more of a physical rehab because they're premature, or is it like you said, autism and other developmental disabilities?
So because they're that young, so there's pretty much there's no diagnosis really. It's just prematurity. So we could be treating like tone, issues or things like that. They will get referred. It's mostly for physical and occupational unless there's a feeding concern, because at that age speech doesn't really come into play unless there's a feeding concern. So which there is a lot of the time, but I would say most of the time it's physical and occupational therapy, and they actually they'll each do their evaluation, but we don't really co-treat, but we actually collaborate because they at that stage in life they overlap so much, these different services. So one nice thing about my team is they're very collaborative. Like they'll discuss the baby, the treatment plan, a lot of parent education. It's important. And then carry over for the parent at home.
So you're actually seeing these kids grow up in a way as your patients.
We've had babies from the NICU that we have a year later.
Wow.
Yeah.
So you get to build a relationship.
Right.
Yeah.
How many children would you say that you're seeing on a weekly or monthly basis within the rehab program?
Probably about 60 every week, children that we see, which is amazing because we had no children. Like a few years ago, we didn't have any pediatric. It was only adults, and which is often the case with a lot of outpatient rehab places. Like normally, they service adults. Like we started this program, and the growth has been really significant, which is nice because there's obviously a need, right? There wouldn't be the volume if there was no need. So it's nice to feel that we're filling a need, and maybe these kids wouldn't be getting the services, otherwise.
You cover like a wide range of services, and when you touch on something like autism, which is it's a broad blanket,
Yeah.
and it's 1 in 33 now,
Right.
which is a crazy number.
Yeah.
Right.
Do you find yourself offering more services based on like developmental disabilities or physical, or is it just a combination now of everything that's
It's really mostly developmental, and I have to say, for pediatric, so for adults, physical therapy is our main volume there. For peds, it's actually speech and OT because there's PT also very involved, but I'd say the majority is occupational and speech, which are addressing a lot of the developmental milestones, and PT is addressing gross motor, but OT's role with the sensory is a big issue for children on the autism spectrum, and we have a high incidence of that, on the island. So we have sensory integration and just speech and language delay for children, as well.
Yeah, I was actually going to ask you a question. Have you done an assessment of the areas around Staten Island, and are there certain conditions that you're seeing pop up more on Staten Island than other areas?
Probably, we have a very high incidence of autism. That would be what we're seeing. I would say probably more than if you went to another state. Just research shows we have a high incidence. That's a lot of what we're seeing because children get services in school, if they're in school, but parents are always seeking, more and more for their children, which we all would, do the same probably. So they're getting services probably 5 days a week in school, but the parents I want them to come and get extra speech and extra OT and work on, the communication board, stuff like that.
Well, I think a big part of that now is that it's recognized, right?
Right.
Like when we were
Yeah.
growing up, it wasn't
Like
recognized.
ADHD, all these conditions that were not identified, not recognized, went untreated. And now, we know so much more about it.
Yeah.
And you do hear, like on Staten Island, what you hear a lot about is cancer clusters. That's what everyone
Yeah.
kind of talks about. Now, apparently, autism clusters are also popping up, which kind of explains why there are so many, I know you're involved with the Grace Foundation, why there are so many autism-related groups here on the island. I mean, they're not here for no reason. And I know from a personal friend of mine who has a son who's on the spectrum. And he lived out in the Midwest in Vegas, and there's very little resources.
Yeah.
The further out,
Absolutely.
New York, Connecticut, New Jersey are kind of the hotbed of autism services.
Yeah, you can't get the same services when you go outside of New York City. I've heard parents say, like, maybe they move from Pennsylvania. Sometimes they move here
Right.
because they said I can't get the same services.
That's my in-laws. My sister-in-law has Down syndrome. My in-laws have a house in South Carolina in Myrtle Beach where they would love to live, but they haven't left Staten Island and New York because of the services that are offered here. And in particular, Staten Island, and a lot of that has to do with the support from the hospital systems here to be able to provide the resources and the services of being able to service the disabled population, and then also be able to develop programming that assimilates and normalizes people with conditions that helps them act and work and live and have normal socialization, just like we have.
Absolutely.
Yeah, and I think some of it gets lost in that when you think of a hospital, rehab is not one of the things you think of when you hear the word hospital. You think of surgeries, you think of...
Yeah, you think of all the acute
Yeah,
stuff,
the acute stuff.
but not the
and then-
ongoing.
Exactly, and or even for, we talked briefly about adults, rehab is that next step after the acute is
Exactly.
taken over.
Yeah.
And it's kind of not seen. Rehab is not. It's kind of that's that after thing, and a lot of times I think rehab is just associated. That's something you do elsewhere.
Right.
You don't
Yes.
do it at the hospital.
Yeah.
But at RUMC, we have this dedicated comprehensive rehabilitation center that is seeing kids, seeing adults, and as you mentioned before, it ties in. We're the only baby-friendly hospital on the island. We see almost 3,000 births. So on those chances where we can have a child that is identified early and referred to you, you continue that continuum of care. And I know the services are not just open to RUMC patients. I mean, anyone...
Yeah, anyone can come, but what's nice is that we can see a baby from the NICU, and they can stay with us for years. I mean, that's the thing about babies and children, right? It's like if an adult has knee surgery, you're getting them for the finite amount of time. But for a baby, they will come for years. And, at some point, the school system picks up, or if the child's not in school, they're still entitled to services from the Department of Ed. But a lot of the times, the parents are like, I'm not leaving. We want to stay with you because we become like their family. I mean, like all the milestones that the child reached, all the gains and all the success, like they feel very attached. So that's a nice thing. It's like you really develop a relationship when you're working with the family.
I think early intervention, my mother-in-law preaches early intervention.
Right.
And if it wasn't for what they did in the 80s with my sister-in-law, I don't think she'd be as equipped as a human as she is. She's very high functioning. She's got boyfriends. She goes to work. She does all these other things, and it's like, if it wasn't for that early attention, and it's probably a really hard pill for a parent or somebody to understand or to swallow or to admit.
Absolutely.
With your offerings, it makes it a lot easier.
Yes.
I mean, do you find that, to Dan's point, do you find that, you have parents who come and you make the assessment and they don't believe it, they don't want to hear it, they don't...
Oh, yeah.
How do you deal
very
with that
common.
situation?
It's a lot of education, and it's a lot of just taking time with the parents. So you can't explain everything in a half an hour, and kind of like shove it down their throat and say, well, this is what it is, and here are the facts. And we all know what the problem is, but you have to keep in mind, like, we've seen, spent years in the field, seen, like, several children like that. this is their, not only the first time maybe they're seeing it, but it's also very personal. It's a lot of working with the parents to get them to accept it at their own kind of pace, in their own time. Some people take longer than others, but I feel that we have them sit on the session, like we'll demonstrate things to them, we'll show them what the progress is, and sort of just kind of get the parent on, to be able to accept the diagnosis.
As a mother of two children, but one who's been through the early intervention process, she's in pre-K now, so now it's the CPSE, but, she's just been getting speech. Have you noticed an uptick since COVID in the demands for speech services?
Yeah, absolutely.
I mean,
yes. For speech and OT, there's a huge demand, apparently because of the services are not really happening in the school because of staffing. I think specifically OT. There's a huge demand for OT, and the schools don't have enough OTs. Yeah. So that we're seeing a lot of demand for OT. Actually, we're hiring another OT because we have so many referrals, and we recently had a developmental pediatrician hired at RUMC, Dr. Marashenko. So she's been really integral in identifying children and referring them to us that maybe otherwise wouldn't have been referred, because once they have a diagnosis, sort of it comes with the the package, like they're getting all the services. I find that there's a big uptick. Yeah. Definitely.
So when you talk about the therapy that you're doing with these kids, we've kind of talked about it, kind of like the 54. Talk us about what now you have the kiddies coming in for a session. What are you actually doing with them?
So it depends on the service. Like PT does one thing, speech has a very different. So it depends, but I think the core is with children is that you can't just, they're different than adults, right? So you can't be like, well, working on your knee, we're doing 10 reps of this, and then we're doing this. With kids, you have to go out of your way to, first of all, sometimes getting them through the door is not the babies, but the older kids, getting through the door, making it fun, giving them breaks, giving them rewards. So it's really not everyone can do it, right? So not everyone can, and that's why with my, my therapists, I don't if they're adult therapists, they pretty much will stick to adults. I won't kind of say you have to treat the babies, because you have to really have a certain approach. You have to have certain training. So it depends really on what we're doing. But they're basically, for a speech session, they would be maybe for a 3-year-old, they would be playing a game. And in that game, which to somebody who maybe doesn't know what's going on, it looks like they're playing. But the therapist is asking questions. They're focusing on vocabulary, WH questions, so who and where and what, that kind of thing. And for physical therapy, they set up an obstacle course, right? So the kid has to jump and then, take a big step. And so working on the gross motor skills, but they don't realize they're working on it. We also have in the sensory gym, which has been such a passion of mine that I'm so proud of, but we have the sensory swing, which the adult staff wants to go in. So we have the sensory swing and we have the rock climbing wall. So that's something that the kids love it. They have no idea they're doing something therapeutic because they just, it's fun. Yeah. So
it's hiding the vegetables under the...
Yeah, exactly. And I have had staff be I'm climbing the wall. So, so that is, the whole thing about a pediatric session is making it fun and engaging, the rapport with the child, because you don't want them to see you next time and go running. You need to build that rapport. They have to feel safe.
Tell that you're super passionate about what you do. So we heard a little bit about your past with Meredith's intro, but how did you find your pathway into this field?
So I'm a speech pathologist by trade. I don't treat patients now because I'm an administrator, but I became a speech pathologist because I just felt the field just kind of spoke to me. I actually worked my whole career with adults, being able to help people after stroke, after, specifically head and neck cancer was one of my specialties. So I felt that I just connected with that. I always wanted to be in healthcare, and I used to want to be a doctor, but then a lot of people kind of talked me out of it. I feel I wanted to help people, and it was a unique way, and there was such a demand, and it's sort of Alex said, it's sort of rehab is not always a well-recognized field, and now I think much more than maybe 15, 20 years ago. But I think people don't realize that patients say who has a stroke, the rehab starts after the hospital. And then it's months and months and months of work with that patient. You're really like getting, a chance to work with somebody and change their life. And I think that's really what always would drive me.
And it's got to be very rewarding to see that, we're talking pediatrics here, to see that child progress as you're working with them.
Yes.
And seeing them, seeing that all the work is paying off.
Yeah.
And at the same time, I imagine it's also managing expectations, because we're all parents in this room. And when maybe it's not happening as fast as you would like it,
Yes.
it's this immediate, it's not working, it's a failure. And it's not, it's just, it takes time.
It takes time. And it is managing expectations of the parent, because sometimes they get frustrated, like they come for a few sessions, they're like, okay, nothing's happening. So you have to like manage their expectation as well. And also sometimes like difficult conversations when, the expectation is not going to be what they, some children never speak, right?
Yeah.
So that's never an easy thing to talk to a parent about. And, you never say never, but you have to at some point say, listen, we're going to look at alternate means, a communication board, and parents, no. They're not going to ever speak if you give them. So now you have to educate. They're not going to not speak. It's just going to help them. And then they're going to get frustrated if they don't have it. So it's a lot of, finesse and education and empathy.
Is there a particular case, without giving away too much, that sticks out in your mind as like, wow, that was like one of the best situations we've ever had?
Well, we had a child that actually came over from another country, and mom like sort of walked in one day with him, and he had muscular dystrophy, like a very severe kind. That's the life expectancy is about 17 years, and he was 15. So the country they came from, there was not even wheelchair accessible anything. So forget resources, like there wasn't even like anything accessible. So she came here and she was referred for like physical therapy, and it was just like a life-changing experience, because like they kind of just walked in and she's like, I'm here for physical therapy, but it really was not only. It was like he needed a wheelchair. He had like ulcers because the wheelchair that he had was not appropriate. So we ended up doing a lot of work with the wheelchair, the seating and mobility people, and Dr. Mendez in her clinic, and the physical therapist and the OT, to just get him just to be comfortably sitting. This to me, like just the look on his face, because we got him like this motorized wheelchair, so he could just move around on his own, and the look on his face, like you would have thought what we did, and to us it seems like, okay, we just changed the wheelchair, but he sticks out in my head. I think about him all the time. They had to move to, I think, to Queens or Brooklyn or something, and mom couldn't come anymore, but she goes elsewhere. But he sticks out in my mind. The whole department actually came together. We chipped in to help pay for the wheelchair. So it was an amazing, and the mom, like she would sit in my office and cry just because she was thankful. And it's like, this is just our job. It's not charity. Like this is just our job. But it goes to show you how it changes people's lives. And it's really not just a job. Like you can't just look at it like, we're just doing the 9 to 5. Like it's not. It really, you have to put your heart into it.
Circling back to why RUMC special, like you chipped in.
Right. You didn't have to
Yeah.
do that.
It's like you're not telling that story to get recognition or anything, but
Yeah, it's
it's
just
something that you do, and that's special.
Yeah. Actually, mom said she had gone somewhere else, and they said there's nothing we could do for him. He's got a terminal diagnosis, and he does. So physical therapy is not going to help, So that's a big difference between being, told something like that and saying, well, what can we do?
Right.
Even if it's like, maintenance therapy or making him comfortable. Much different than telling the poor, mom, like, there's nothing we can do.
No, you brought him
So-
comfort and
Right.
independence by doing that.
Quality of life.
Yeah.
Right,
Quality
exactly.
of life,
Whether
and
he's
people
got-
forget about quality of life.
Whether he's got 3 years or 5 years, you try
Yeah.
to make them the best
Make
years
it
he
the
can
best.
have,
Yep.
as opposed to just writing him off because he's only got 3 to 5 years
Exactly.
to live. That's
So I think that's our difference at RUMC. I feel like my staff, they're so dedicated and passionate, which I feel like you usually don't get into this kind of field if you're not,
Yeah.
but they really will go above and beyond for their patients.
And as these children age, through life and through the program, how closely, once they are in school, do you work with the DOE?
So we actually are one of the contracted providers for DOE, which
Okay.
is something I worked, it was a long process to get that in place, but it allows a child to come to us for services, like I mentioned earlier, if there's no OT in the school or not enough OTs.
Yes.
The DOE has to give them a voucher to get the services elsewhere if it's mandated in their IEP. We're one of the sites that they can go to. And one of the benefits is that we have all the services. We have PT, OT, and speech, because a lot of children have multiple services on their IEP. So parents some places just offer speech, so then they'll have to go one place for speech and one place. So we offer everything. We have, obviously, the hours to accommodate the after school. And so, that's, I think, a huge benefit for parents.
Oh, 100%.
And also, they have a hard time finding agencies that provide that. So we get calls, and they're like, where have you been? Like, we didn't know. And we're so happy that, that also is a good feeling,
No, of
that we can
course.
help in that way.
Being that this is a kind of a one-stop shop, is there anything about the pediatric rehab program that we haven't discussed that you would like to let people know about?
So I think, and this is something I just realized recently, we're starting to get pediatric patients from Manhattan, from the Bronx, from Queens. Now that's like quite a trip, right,
Yeah.
for people. So babies, like we're getting like say 3 and under. Dr. Mendez and she's our like chair of the outpatient pediatric. She's a physician. We work very closely together, and we kind of did our research and realized that people there's no outpatient services really for children under 3. They get put into the early intervention system, and the system's overloaded. There's staffing issues. Kids wait a long time to get seen. So parents are traveling just to get these services, like 2 years old, 18 months old. So that, I think, is really unique, and we've tried to find them places closer because we don't want them to have that burden of traveling, but it's very limited. So I think that's unique to our facility, which I'm really proud of.
We talked a lot about these programs that you have, and we keep saying the term referral, but if anyone's listening to the podcast and sees this and is curious about, can they make an appointment, or is it strictly doctor referral to access the services you've been talking about?
So we need a physician referral, not for the DOE cases, that's a different process altogether, but for a parent that has concerns about their child's speech or walking, anything like that, they should talk to their pediatrician, and a pediatrician can write a script, and then they can call us and we can schedule an evaluation.
And if anyone is listening to the podcast, our rehabilitation services are listed on our website, rumcsi.org, and the contact information for Kristine and her team. But I mean, it's again, it's an amazing when you deal with children. It's obviously, like you said, it's different from adults.
Yes.
And they can't sometimes, as you're talking about with NICU graduates, can't communicate what's wrong.
Yeah.
So you have to play a little bit of detective work, I imagine. But I mean, for all that you guys are doing, and again, to your point, when you have people traveling to you from other areas, that speaks a lot to your program
Yes.
and what you're doing. And I think knowing that you're a resource here, because if you live on Staten Island, you have that kind of, forgotten borough kind of syndrome.
Yes.
I don't want to leave Staten Island, but I
Yeah.
may not know your programs here. So I've been going to Jersey, I've been going to Manhattan.
Yeah.
It's actually right here in the backyard.
Exactly.
So
yeah.
that's
So
great.
that's nice.
Absolutely. Well, thank you so much for your time today, Kristine,
for
and for
having me.
all that you do to help our children. That about does it for this episode of RUMC Connections. I'm Meredith.